Welcome to Cardio Radio, a podcast of the Ohio Cardiovascular and Diabetes Health Collaborative, also known as Cardio. This is Dr. Michael Constant from the Case Western Reserve University School of Medicine, and I serve as the principal investigator for Cardio, a statewide network of Ohio's 7 medical schools. Cardio is funded by the Ohio Department of Medicaid and shares best practices to improve cardiovascular health, diabetes outcomes, and to eliminate health disparities in Ohio's Medicaid population. The opinions and recommendations in this podcast are those of the presenters and not those of Cardio and its sponsors, and are not intended to be a substitute for medical advice. I hope you enjoy today's podcast.
Hello, I'm Dr. Danette Conklin, an associate professor of psychiatry and of reproductive biology at Case Western Reserve University School of Medicine, and I'm a member of Cardio's Team Best Practices. I'm also the Director of Behavioral Health Services for Bariatric Surgery and Weight Management at University Hospitals Cleveland Medical Center. On today's podcast, we will explore the evolving science surrounding cardiovascular and brain health. Across the world, neurological and cerebrovascular conditions account for an enormous and growing share of disability and mortality, affecting 1 in 3 people globally and representing over $3.9 trillion in annual healthcare spending. As our population ages, the burden of stroke, cognitive decline, and dementia is expected to rise substantially. Today, we are joined by Dr. Alan Lerner, Emeritus Professor of Neurology at the Case Western Reserve University School of Medicine and the former Neurological Institute Chair for Memory and Cognition at University Hospitals. He has had a long clinical career in multidisciplinary assessments of memory and will help us reframe brain health using a wellness model rather than a disease model, one that spans the entire lifespan and recognizes the brain as a dynamic, resilient organ impacted by cardiovascular, metabolic, social, and behavioral factors. Dr. Lerner, thank you for joining us today.
Thank you so much for inviting me. I'm happy to be discussing this topic with you.
So, Dr. Lerner, to set the stage, can you start by explaining what we mean by brain health? I think this is a new term and may be a new concept for our listeners.
You know, when we talk about brain health, I think it's important to recognize, as you said earlier, that we're really talking about a wellness model rather than a disease model. Instead of centering pathology, we're looking at how the brain functions across the entire lifespan. The earliest framing of brain health dates back to 1948, but the more contemporary understanding emerged around 2010. Then, in 2017, the American Heart Association and the American Stroke Association expanded the concept further, emphasizing the interconnectedness of neurological, vascular, and mental health. The World Health Organization offers a definition of brain health that I find incredibly useful. They describe brain health as a state of functioning across cognitive, sensory, social, emotional, behavioral, and motor domains. And what's key is that this definition applies regardless of whether someone has a diagnosed disorder or not. It's about enabling individuals to reach their full potential over the life course, and that's a powerful reframing.
I love it. So what I hear you saying is this isn't a static idea. It's a framework shaped by decades of scientific progress. Is that right?
Yes, when we talk about brain health, we're talking about a very broad umbrella. It includes mental health conditions, neurological disorders, and cerebrovascular disorders. The umbrella of brain health also includes conditions that affect a large proportion of the population: dementia, stroke, depression. These are not only conditions of the brain, but they're also amongst the leading causes of death and disability worldwide. And of course, with the global population aging at an accelerated rate, we're expecting the number of brain health-related disorders to rise. Dementia is a prime example. The projections are sobering. which is why this wellness-oriented, lifespan-focused approach to brain health isn't just conceptually appealing, it's a public health imperative. If we want to reduce the future burden of disease, we have to think proactively about supporting brain health long before pathology emerges.
Wow. So thank you, Dr. Lerner, for laying that foundation for what brain health means. Can you help us visualize the physiological connection between the heart and the brain? Can you walk us through how cardiovascular health influences brain function, stroke risk, and the development of neurodegenerative diseases?
As highlighted in the American Heart Association, AHA's 2024 scientific statement on cardiac contributions to brain health, the heart and brain are deeply interconnected through a bidirectional relationship. The heart supplies the oxygen and nutrients that sustain neural tissue, while the brain provides autonomic regulation that keeps cardiac function stable. When that system is disrupted, particularly in conditions like heart failure, atrial fibrillation, coronary artery disease, we see meaningful downstream effects on cognitive health. The AHA statement also emphasizes that vascular risk factors influence cognition through multiple biological pathways. And because of that complexity, relying on single, isolated interventions may not be enough to preserve cognitive vitality. One of the most frequently cited examples is the FINGER trial, the Finnish geriatric intervention study to prevent cognitive impairment and disability, which demonstrated that a multi-domain approach combining diet, exercise, cognitive training, and vascular risk factor control produced measurable cognitive benefits over 2 years. But it's equally important to acknowledge that other randomized, multimodal trials have produced mixed or conflicting results. This has led to the hypothesis that prevention efforts may need to begin earlier and run longer, potentially starting in young adulthood, to truly understand how vascular risk factors shape dementia risk later in life. Still, from a public health perspective, the epidemiologic evidence is remarkably consistent. Preventing and treating cardiac disease early is one of the most effective strategies we have for maintaining cognition as people age. That's why the AHA points to culturally and age-tailored education campaigns and to the early adoption of healthy lifestyle frameworks such as Life's Essential 8, a promising tool to reduce the population-level burden of dementia. The message is clear. Protecting the heart is one of the most powerful ways we can protect the brain.
Wow, that's very interesting. So, Dr. Lerner, now that you provided a clear backdrop for us, I want to specifically ask you about risk factors. What are they? How do they show up in real-world health outcomes, particularly in communities disproportionately impacted by conditions such as hypertension and diabetes?
Great question, Dr. Conklin. Since we discussed the connection between the heart and brain health, we have to look at the shared risk factors that drive disease in both systems. The most important ones are hypertension, diabetes, obesity, hyperlipidemia, and chronic inflammation. These conditions don't just affect the heart, they also damage the blood vessels in the brain, leading to reduced blood flow, increased stroke risk, and accelerated cognitive decline. Let's take hypertension as an example. It's one of the most common and dangerous risk factors. In fact, as of 2023, about 48% of U.S. adults were living with high blood pressure. Over time, elevated blood pressure weakens and narrows blood vessels, including those in the brain. This leads to microvascular damage, which is strongly associated with cognitive impairment and dementia and even Alzheimer's disease. Hypertension also increases the risk of other cardiovascular disease like heart failure and stroke, which further compound the risk to brain health. Now, when we look at how this plays out in communities, especially among African American populations and older adults, we see a troubling pattern. These groups are disproportionately affected by hypertension and diabetes, often due to a combination of social drivers of health, limited access to preventive care, and hereditary factors. This means they're not only at higher risk for heart disease, but also for stroke and cognitive impairment. And this impact is far-reaching. It affects families, caregivers, and entire communities.
So, Dr. Lerner, I think I recall you saying that, we're going to talk about this across the lifespan. And so much of what has been talked about so far is about older adults. But what about risk in younger patients?
It's essential for clinicians to recognize that cerebrovascular disorders aren't limited to older adults. In fact, epidemiologic data shows that 10 to 15% of all strokes occur in adults aged 18 to 50, underscoring the importance of vigilance in this age group. Many of these conditions have genetic or hematologic origins.
I'm glad you pointed this out. That's very important to note. So, we have touched on this in our recent podcast on lipids, and we'll link it in the show notes. So, Dr. Lerner, are there other concerns for our younger patients?
Several inherited thrombophilias significantly increase stroke risk in young adults. These include sickle cell disease, factor V Leiden, protein C, protein S, and antithrombin deficiencies, and prothrombin gene mutations. A 2025 retrospective study from the University of Oklahoma found that hypercoagulable states accounted for over 54% of ischemic strokes in young adults. Peripartum strokes, often linked to cerebral venous thrombosis in the setting of preeclampsia or eclampsia, remains a critical cause of morbidity in young women. A stroke occurs in approximately 20 to 40 of every 100,000 pregnancies in the United States. Lastly, cervical and cerebral artery dissections are recognized as one of the leading causes of stroke in young adults, and they may occur spontaneously or in association with connective tissue disorders.
Dr. Lerner, thank you for bringing this to our attention. So I'd like to ask you, are there early warning signs, either physical or cognitive, that people should be aware of when it comes to vascular-related changes in the brain?
Vascular-related brain changes often develop slowly, and the early stages can be incredibly subtle. We know from longitudinal cohort studies that up to 1/3 of adults with early small vessel disease show mild executive dysfunction or slowed processing speed long before a formal diagnosis is made. We also see mood and motor changes. Microvascular ischemia is associated with a 2 to 3-fold increase in late-life depression and motor slowing, changes in gait, balance, or coordination, often reflecting disruption of frontal subcortical circuits. Subtle gait changes can be surprisingly informative. Research from aging cohorts show that slowed gait is associated with higher white matter hyperintensity burden, reinforcing the link between motor function and microvascular brain injury.
You're saying these subtle motor changes, these aren't just about aging. We can really think of them as vascular signals?
That's correct. Transient ischemic attacks are another major red flag. Even if symptoms resolve within minutes, transient ischemic attacks carry a 10 to 15% risk of stroke within 90 days, with the highest risk in the first 48 hours. So temporary weakness, visual loss, or speech disturbance should never be dismissed. For women, menopause adds another layer. Neuroimaging studies show that during the menopausal transition, up to 60% of women report brain fog symptoms, and measurable declines in processing speed and working memory can appear. These changes often overlap with vascular risk factors that rise in midlife, making awareness even more important. What's especially concerning is that these early signs often go unrecognized in communities with limited access to neurological care. Populations disproportionately affected by hypertension and diabetes, particularly Black and Latino communities, face higher rates of undiagnosed small vessel disease and stroke. That's why education, screening, and culturally tailored outreach are so essential. The encouraging news is that early intervention truly matters. Managing vascular risk factors in midlife, blood pressure, glucose, cholesterol, may reduce dementia risk by 45% later on.
So this is a big shift in how we conceptualize this care, and certainly a lot of ground to cover for primary care providers. I mean, you mentioned elderly adults, you mentioned adults 18 to 50, perinatal, postpartum women, and menopausal women. So, this is actually a lot to cover on top of all the other risk factor modification and chronic disease management. So, how do clinicians start the conversation about brain health with patients and or caregivers?
Primary care providers are uniquely positioned to start the conversation about brain health and how to maintain optimal brain function. This should be started early and at all life stages, including aging adult patients and their families. Two practical approaches to screening and assessment of brain health is to start with asking what matters most, an age-friendly approach from Veteran Affairs, which will help providers understand and prioritize a patient's unique healthcare needs, including in the context of brain health. For example, asking questions such as, what are the things you want to keep doing as you age? Or, is there anything getting in the way of what you like to do?
I really like those questions. What are the things you want to keep doing as you age? And, is anything getting in the way of what you like to do? Those are great questions. And we can link to the tool in the show notes, What Matters Most.
Another way to focus on brain health assessment is to focus on the mnemonic, Safest Brains initiative developed by the American Academy of Neurology, which defines the various domains of preventive and maintenance measures that may support healthy brain development or reduce recurrence or slow progression of disease. These include sleep, affect, mood, and mental health, food, diet, and supplements, exercise, supportive social interactions, trauma avoidance, blood pressure control, risk control of metabolic and genetic factors, affordability and adherence, particularly of medications, infection, negative exposures, and structural and social determinants of health.
That's a great mnemonic, and we will link to the diagram in the show notes. So what about evidence for these modifiable risk factors impacting cognitive decline?
The U.S. study to protect brain health through lifestyle intervention to reduce risk, also known as the U.S. Pointer Study, was a 2-year, multi-site, randomized clinical trial funded by the Alzheimer's Association that tested 2 lifestyle interventions in older adults at risk of cognitive decline. Both interventions, focusing on physical activity, improved nutrition, cognitive and social engagement, and health monitoring, improve cognition relative to typical aging. The cognitive benefits were even greater for participants in the more structured intervention group, helping to protect thinking and memory from the normal decline that often comes with aging over the nearly 2-year period of the study. It is important to note that despite an improvement in cognition, it is not known whether such an intervention decreases the risk of dementia, which takes much longer to develop.
So, Dr. Lerner, what is the most effective way to communicate this to patients and help them understand the importance of brain health?
There is a lot one can do, starting with having candid conversations about brain health, as mentioned before. Emphasize lifestyle modification, early detection, and initiating proper treatment are key. This can delay the effects of many brain diseases. The 2025 joint guidelines from the American Heart Association and the American College of Cardiology highlight the importance of earlier intervention with lifestyle modification. Healthy lifestyle behaviors, such as eating a nutritious diet, being physically active, and maintaining or achieving a healthy weight to prevent risk factors for cardiovascular disease, including heart attack, stroke, and heart failure, as well as kidney disease, cognitive decline, and dementia. Clinicians can continue to educate their patients to engage in multimodal lifestyle modifications. One small change someone makes today can have a meaningful impact on both heart and brain health down the road. To achieve the best health outcomes for patients, clinicians should address modifiable cardiovascular risk factors such as hypertension, diabetes, and obesity at every encounter.
Wow, that's a great suggestion. Dr. Lerner, I'm going to pivot a bit and ask you more about cognitive decline. You mentioned earlier your long career in the clinical care of cognitive decline. Can you walk us through what your assessments looked like? How did you screen patients? What kinds of questions were you asking? And what signs were you watching for?
Our clinic focused on caring for patients with cognitive challenges, and one of the keys to doing that well was a multidisciplinary model. We work closely with social work and neuropsychology, an approach that's ideal, even though it may not be available in every community. Age is one of the first things we consider. When someone under 65 presents with cognitive symptoms, that's a red flag for subspecialty evaluation because we start thinking about frontotemporal dementia and other early onset neurodegenerative conditions. On the other end of the spectrum, in patients over 85, most cognitive impairment reflects mixed pathology, Lewy body disease, vascular changes, late life white matter injury are all common contributors. We should always focus on the care ecosystem. Who is supporting the patient? What can we modify? That's where frameworks like What Matters Most and Safest Brains really help guide the conversation towards function, safety, and values.
So, Dr. Lerner, what about the traditional memory tests, such as the Montreal Cognitive Assessment, also known as the MoCA, or the VA SLUMS tool? I think most of our listeners are familiar with them, but we'll link them in the show notes.
These tools are absolutely part of the assessment, and in most cases, they've already been administered in primary care settings before a patient reaches a specialist. The MoCA, for example, is widely used to detect early cognitive impairment and takes about 10 minutes to administer. A score of 26 or higher is considered normal, although results can be influenced by educational level and other baseline factors. But like any screening tool, they have limitations. Ceiling effects, cultural and educational biases, and the inability to capture real-world function. That's why I often relied on a more global question directed to the caregiver. How is mom doing? Family noticed changes in activities of daily living, managing medications, preparing meals, navigating social situations, long before those deficits show up on a cognitive screener. These observations aren't quantitative, but they're incredibly powerful. They help us understand whether someone is living alone safely, whether we can increase social engagement, reduce fall risk, or keep them meaningfully active.
That's another great question. How is mom doing or how is dad doing? But what about the popular approaches to brain health, such as crosswords, exercise, or avoiding falls? What does the evidence say, and what has your experience been?
The evidence for brain games is modest. Improvements tend to be task-specific. People get better at the crossword or the app they're practicing, but the gains don't reliably generalize to broader cognitive domains. The best results seem to occur with so-called speeded results, things like whack-a-mole, video games, or dual decision kinds of paradigms. And because there's little commercial incentive, we don't have large, well-funded trials. An exception to this is the NIH-funded randomized clinical trial, the ACTIVE study, which was just recently published, which involved having participants play 8 to 10 hours of brain games, again, focusing on speed and attention, and looked at the rates of Alzheimer's and related dementias up to 20 years later. Individuals who were randomized to the brain games and received booster training 11 and 35 months afterwards showed a statistically significant lower risk of diagnosed dementia over 20 years of follow-up.
This is a great landmark study here and hot off the presses. It is amazing to have a 20-year follow-up like this. So, Dr. Lerner, going back to the evidence for popular approaches, what more can you tell us?
Exercise and social engagement have more consistent support, though the effect sizes are still modest. They're low-risk interventions, and for sedentary patients, even small increases in activity can be meaningful, provided we're mindful of fall risk. As for fall prevention programs, the evidence that they slow cognitive decline isn't strong, but we do know that avoiding traumatic brain injury is critical for long-term cognitive health.
So, this is a curious question here, Dr. Lerner, because the world has changed so much in terms of, how we balance our finances. So, we used to ask, can your mom or dad balance the checkbook? But that may be an outdated question today.
Exactly. Physical checkbooks are disappearing. Instead, we use tools like the Financial Capacity Instrument, which evaluates whether a patient can perform tasks such as calculating a grocery total or making correct change. Families often provide invaluable insight here because they are the first to notice when financial judgment starts to slip.
So, what about driving? That's always a difficult topic for patients and families.
It is, and it is emotionally charged. It's not really about transportation. It's about freedom to go where you want to go, when you want to go. The most important thing is to have a strong therapeutic relationship before initiating the conversation. Driving impacts identity, independence, and safety all at once, so approaching it with empathy and preparation is essential.
So, Dr. Lerner, you've mentioned families, caregivers, and support people as being key for history, early recognition, and ongoing support. They're absolutely central to longitudinal care, but how can clinicians better support caregivers?
Caregivers really are the backbone of cognitive and vascular-related brain health management. They're often the first to notice subtle changes, the ones monitoring day-to-day symptoms, coordinating appointments, and advocating for the patient. And we know from the literature that caregiver burden is substantial, particularly among women, older spouses, and individuals in marginalized communities who consistently report the highest levels of strain and stress. That burden only increases as cognitive impairment progresses, with studies showing a clear relationship between the severity of cognitive decline and the level of caregiver stress. Because of that, clinicians need to intentionally include caregivers in the decision-making process. The National Institute on Aging highlights that caregivers play a critical role in maintaining quality of care and care coordination, especially for patients with dementia or vascular cognitive impairment, and that supporting caregivers directly improves patient outcomes. Education is another essential piece. After events like a stroke or in patients with long-standing, poorly controlled vascular risk factors, caregivers often need guidance to recognize symptoms, understand the trajectory of the condition, and anticipate what changes may come next. Evidence-based caregiver education programs have been shown to improve quality of life for both patients and caregivers, particularly when they are culturally tailored and grounded in practical strategies for daily care. These programs may be offered by clinics or through local chapters of the Alzheimer's Association.
So, what I hear you saying, whether it's helping caregivers interpret new symptoms, connecting them with community resources, or simply validating the emotional and logistical challenges they face, we as clinicians or healthcare providers can have a powerful role in supporting the people who support our patients. Is that right?
That is correct.
So, Dr. Lerner, we've heard so many valuable insights from you today about brain health. What would you say are the major takeaways for our listeners?
First, brain health is inseparable from cardiovascular health. Lifestyle-related factors drive both cardiac and cerebrovascular disease, and early aggressive management can improve long-term cognitive outcomes. Second, subtle changes in cognition, gait, mood, and executive function can signal early vascular compromise. Recognizing these signs, especially in high-risk and underserved populations, can enable earlier intervention and potentially prevent major events like stroke or progressive cognitive decline. Third, Clinicians play a central role in reframing brain health as part of routine preventive care. Approaches such as What Matters Most and the Safest Brains framework give providers practical tools to integrate brain-focused screening and counseling across the lifespan. And finally, caregivers are essential partners in monitoring symptoms, ensuring safety, supporting treatment adherence, and maintaining quality of life. Empowerment of caregivers with education and resources strengthens outcomes for the entire care team.
Dr. Lerner, thank you for speaking with me today. This was very informative.
Well, thank you for having me.
And a special thank you to you, our listeners, for tuning in to Cardio Radio.
This concludes today's podcast. Be sure to visit cardio.org to learn more about the Ohio Cardiovascular and Diabetes Health Collaborative.